Okay, I think we have quite enough people here today. So this is a seminar really teaching us about how to get into the radiology program. And we've got two wonderful trainees who already got in, so they're pretty much well experienced in it. So we've got Dr. Sumaya Gurhan and Dr. Khalid Kareem. Okay, so I would like everyone to put all their cameras and mics off. And if you have any questions, we have a link in the chat that will let you put questions on through there, and we can go through Q&A at the end. And please don't forget the feedback forms. Okay, so let's take it away, Dr. Khalid Kareem.
Hello, assalamu alaikum guys. My name is Khalid. I'm a current ST1 trainee in the West Midlands. Let's just set the PowerPoint up. Yeah, so the plan for this evening is I'm going to quickly talk about mainly the application process for radiology and some tips that I found useful. And then Sumaya will talk about what it's like to be a radiology trainee, a day in the life sort of thing. Next slide. Yeah, just a little bit about me. I studied medicine at King's College London. I graduated in 2020. I then went on to do my foundation training in Essex. After that, I did a year of F3 in London, doing locuming and sort of traveling here and there. And then now I've moved to Birmingham for radiology training, and I'm finishing my first year of training. Next slide, yeah. So radiology is a 5-year run-through program, which basically means once you apply and you get in the first time, you stay in the training program until you become a consultant and you CCT, which is good because you can sort of plan your life around the 5-year training program, and you don't have to go through multiple interviews and applications. If you wish to do IR, that's an extra year. Some training programs offer the IR sort of, as an IR stream where you apply for IR and you don't do the application again. But if you don't choose to do IR initially, you can still decide in ST3 to subspecialize in IR, and you're not at a disadvantage. A rough timeline for the applications. Firstly, you apply on Oriel, and the applications open in early November and they close at the start of December. Around mid-December, they send out invites for you to book your exam slot, and the window to take the exam is in January. Results are released in February, and if you meet the cutoff, you get invited for interview, which happens in early March. And at the end of March, offers are released. And following this, you have the option to hold, upgrade, or decline your offer. And this is in April, the deadline. If you don't get an offer initially, there is still a chance you could be offered a place later down the line, if your rank is high enough and there are people who drop out or decline their offers. Next slide. So as you probably know, radiology is getting increasingly competitive, but it doesn't necessarily mean that it's impossible to get into. These are some numbers from 2023. There were about 3,000 applicants for 350 training posts, which is a ratio of almost 9-1. However, once you do get to the interview stage, the ratio drops to just under 2-1. So it might seem a bit daunting initially, but you have to remember also a lot of people nowadays apply to multiple specialties just for the sake of it, because it's literally just a press of a button, and some of these people don't necessarily have an interest in radiology, and as a result, it just inflates the numbers. Next slide. So yeah, this is just a graphic showing the popularity of radiology increasing rapidly over the last few years, and most likely it's going to continue going up in the upcoming years as well. Next slide. Thank you. In terms of weighting, the MSRA exam counts for 20% of the application. The portfolio aspect counts for 30%, and the interview has increased from 30% previously to 50% this year. You need to meet the MSRA cutoff score to be invited for an interview. And as you can see, the cutoff score has been rising slowly over the last few years. It was 521 in 2021, and this year it's reached 555. This is something that you have to sort of have in mind when you're preparing. Realistically, I think you need to aim for around 570 this year. And to do that, you really need to prepare well over a period of at least 2 to 3 months in order to sort of get a score like that. And I don't think it's something that you can sort of cram in a few weeks. But I'll get onto the MSRE next. Next slide. So yeah, just to emphasize, don't underestimate this exam. The exam itself is comprised of 2 components. There's a clinical problem solving paper, and then there's a professional dilemmas paper, aka a situational judgment test. There's plenty of resources out there, but me personally, I found Past Medicine really useful for the clinical aspect. And then MCQ Bank, which is another question bank, useful for the clinical and the SJT component. The MCQ Bank has a lot of questions that came up previously, which they label as repeats, and some of them actually do come up again. So it's worth doing just for that aspect. The MCQ Bank is not as sort of comprehensive as Past Med, but because of the sort of similarity to the actual exam, it's worth doing. In terms of the SJT component, don't neglect it. Some people are of the opinion that you can't really revise for such an exam, but I think it's such a crucial aspect of the exam. It's worth 50% of the exam, so it can literally make or break your score. So what I'd advise is to go through the official sample paper. There's a sample paper on the MSRA website, and really dissect and understand the reasonings that they give for each question. Try to get yourself thinking in the same way that they do. A lot of the time, what you would do in these scenarios might not be, or is completely different to what really happens in real life. So you have to be careful not to think in that sort of way. But the only way that you get yourself thinking in the same way is by actually doing the papers, the official papers. So if you go back one slide somewhere, sorry. And then just a quick point on courses. There are courses such as eMedica, which have good reviews for SJT, and it might be worth attending, especially if you have sat the exam before and you've sort of struggled on that aspect of the exam. So that might be something that you could have a look at. And lastly, it would be good to read the GMC's Good Medical Practice to familiarize yourself with some of the principles that you apply and come across in the SJT exam. Next slide. Moving on to the portfolio, this is worth 30% of the application. It is initially self-assessed, and there are 7 domains for which you can get points for. The maximum total you can get is 45, and if you reach the interview stage, it is reviewed by a consultant on the recruitment team, and they score you based on the evidence that you provide. You can be a little bit ambitious with your scoring, but as long as you don't lie, I think it should be fine. They say that if you exaggerate in multiple domains, or you lie, then they might reject your application, and it might become a probity issue. But if you're ambitious in your scoring, the worst that they can do is mark you down, as long as you're not lying, that is. I think my application, they marked me down by 12 marks, but I appealed it afterwards and they gave it back to me. So even if they do mark you down and you do feel like you do deserve those marks, then definitely appeal. And they say that they can also mark you up if you have undersold yourself, but I'm not sure if a lot of people undersell themselves, but that is a possibility. If you go to the next slide. So I'll just quickly run through each domain quickly, and how you can aim to get a decent score. So for this domain, commitment to specialty, I think if you are serious about radiology, I think you have to sort of get full marks in this domain because it's very easily attainable. 10 marks is you'd get by doing multiple significant exposures to the work of a radiology department. So 2 different taster weeks will get you full marks in this, as long as they're in different settings, for example. By doing a taster week in IR, and then doing a second taster week in diagnostic radiology, or doing 1 taster week in a DGH and another in a tertiary hospital, that will get you full marks, 10 marks in that domain. Try and get that sorted as soon as possible if you are applying this year. And yeah, just email your local radiology department and try and arrange it as soon as possible. If you are having difficulty arranging one, and you are based in the Midlands, you can feel free to email me or Sumaya, and we can try and put you in touch with someone. But most radiology departments are quite friendly and they are accommodating for taster weeks. So yeah, try and sort that out as soon as possible. You also need a letter from the consultant or the department that you did the taster week as part of your evidence. Domain 2. So this second domain is leadership and management, and is a little bit trickier to obtain full marks in. So unless you've had a national level leadership role involved in radiology, realistically, you're going to be aiming for about 3 to 5 points in this domain, which is not bad because everyone will be in the same position and not many people will be able to get full marks here. So you will get 5 points if you have had a national role, a national leadership role, such as a BMA rep, for example. 3 points will get you, you can get 3 points if you have experience in a healthcare related leadership role that might be local. So that can be something like a student society, university, or something like that. And then finally, 2 points for local leadership role outside of healthcare, so anything to do with charity, sports, things like that, that can get you 2 points. But if you have anything related to your medical school where you've been involved in a medical society, then that can get you 3 points. And if you have anything better, then you can try and aim for more. Next slide. Domain 3 and domain 4 are both on teaching, and they can be tricky again to get full marks in. So for domain 3, it says here, having a major contribution to a national or international training teaching program. So all of these roles have to be 3 months or longer, and having a national or international teaching program, this can be done if you organize a teaching program for organization like BSMA, for example, and you do it over a period of 3 months. That would count as a national teaching program. You could do something if you coordinate with other junior doctors at different hospitals and sort of arrange some teaching over Zoom on different topics. That could also count as a national teaching program. But the key thing is that it's over 3 months. And then 2 points will get you a single one-off teaching session for medical students, for example. Actually, for 4 points, actually have made a major contribution to a local or regional teaching program. So if you teach medical students for like 3 months, it doesn't have to be every week. Every other week can sort of suffice. If you teach them sort of any part of the medical curriculum, get feedback forms, and get a consultant to sign you off that you've done this, that could give you 4 marks at this domain. The next domain. Again, this one is a bit difficult to get full marks as well. If you have a master's or formal teaching qualification, such as a PG cert, you can get 4 or 5 points, depending on which one you have. But then if not, the least you should aim for in this domain, I think, would be 2 points. Evidence of other training and teaching methods after study of at least 2 days. So Train the Trainer is a course basically that you can do online. On the next slide, there's a website where you can do it on the Higher Education England website. They charge £99 for the course, and but if you have an NHS email, you can do that for free. In terms of completing it, it doesn't take 5 weeks. You can do it a lot quicker. Yeah, so that's 2 points I think you can easily get as a minimum. Domain 5 is audit and quality improvement. So this section I think is also very achievable to get up to maximum points, at least 5 to 7 points, especially if you start soon. To get full marks, you must complete 2 audits, which are closed loops, or a QIP that has shown to have resulted in some change in practice. So you can either go to your local radiology team and ask them to get involved in an audit, or you can go to the radiology Royal College of Radiologists website. They have a section called RCR Audit Live, and they have literally hundreds of audits templates where you can just pick a random one that doesn't seem too sort of strenuous or long. And they tell you step by step how to do it in terms of like patient numbers, what to analyze, what to look for. And it is pretty self-explanatory. So you can just email a consultant, ask them to supervise it, and they will write you a letter once you complete it. If you do this twice, you get the full marks. That would be 7 points. I think it's definitely achievable if you start soon for this year. The next domain. So the next domain 6 is about academic achievements. If you have a postgraduate research degree, that will get you 4 marks, but a lot of people won't have that. If you have a publication related to radiology as the first author, that will get you 4 marks. Again, things like case reports might suffice here, but a lot of people might not have that as well because it needs to be related to radiology. And then 3 points here, I think, is definitely achievable. So the audit that you do in the last domain, if you submit it to a conference, and it gets presented as a poster or oral presentation, that will give you 3 points basically. If you have any case reports that you've done already that are related to radiology, you can submit that to loads of different conferences and get that presented as a poster. That will again get you 3 points. If you have any other publication that's not related to radiology, that will get you 2 points. And then finally, if you have any poster or oral presentation that is not related to radiology, that will get you 1 point. Next slide. Radiology Residents Forum. This is an organization / conference that was organized. It's organized on a yearly basis, recognized by the Royal College of Radiologists, sorry. And it's an international conference. It's a recognized conference by the RCR, and they accept abstracts and they accept attendance for free to anyone interested. So a lot of the conferences nowadays are sort of they charge a lot, so some people might not be able to afford it. So this is a conference that you can easily submit an abstract to. If you've done an audit already or a case report, if you submit it there, that will give you the 3 points needed in the previous domains. And there's a high chance that you'll get accepted to present there as well, whether that's an oral presentation or a poster presentation. Next slide, please. And then prizes. Yeah, you either have a prize awarded at your university or at a conference. If you have that, great. If you don't, it's a bit difficult to get any points here. But if you have any prizes, there's no harm in you just including it, and then if they reject it, they can reject it. But this is quite specific. Yeah. Next slide, please. So interview. So the interviews were 50%, and the interview format has changed this year after being the same for the previous 3 years. This year they've had 2 10-minute stations rather than 1 10-minute station that was present last year. The first station was a clinical prioritization station where they asked you to either talk through an ATE assessment for a patient that they gave you, or they gave you a scenario where there were 4 different patients who required 4 different scans, and you were expected to talk through how you would sort of prioritize them. That was the first station. The second station was more sort of skills-based, and it was divided into 3 or 4 questions, and they asked you about sort of tell me a time where you've demonstrated a certain skill or what skills are required to sort of succeed in radiology, that kind of thing. In terms of resources, there are organizations that offer a lot of one-to-one or group interview practice, such as Radcast, UKRST. But I think the best thing to do would be, if you know any ST1s, then approach them when the time comes and do a few practice sessions with them. And hopefully you will be all right, inshallah. I think the interview section can be a whole talk in itself, but I'll leave it at that for now. And I'll pass it on to Sumaya.
Thank you so much. Okay, appreciate it. I'm just going to share my screen again. One second. Okay, can you see my screen?
Yeah.
Yeah. Okay, great. Thank you, guys. All right. Okay. So thank you so much to Khalid for covering how to apply for radiology. So I'll be kind of covering the other end, which is life in radiology. So essentially, I'll be looking through the training scheme structure, types of radiology training, the exam, FRCR, subspecialty training, opportunities, scope beyond CCT, and as well as the pros and cons of radiology. And then afterwards, we'll be doing a Q&A session to end. Zakaria has been posting the Slido link and all the Slido code. So whilst I'm talking, feel free to start posting your questions so that we can get started on that. So just in terms of background about myself, so my name is Sumaya. I went to medical school at University of Nottingham, did my Bachelor's of Medicine Surgery, as well as Bachelor's of Medical Sciences. I then did my 2 years of foundation program, covered a variety of jobs, from psychiatry to public health to breast surgery. I also did a locum year, and I locumed in cardiology, gastro, general surge, and general medicine. And I am now a radiology registrar in the West Midlands. Myself and Khalid are in the same program, and I'm an SD3. And the question I always get asked, did you always want to do radiology? The answer is a firm no. So it's not something that I always wanted to do. So I'm going to go on from the point of where you get acceptance. And I thought we'd start off with no one will reap except what they say. So I'm hoping after all of the work that you guys have done, inshallah, you'll get an offer and then we'll see how life goes. So in terms of radiology, these are quite a lot of things I'm going to talk about are things that I personally did not know too much about. So there's 2 particular types of programs in radiology. One, we call it the traditional program, and the other one is an academy style program. So you kind of need to look at what is your learning style, and what does it suit better to. So in terms of traditional, what this is, it's basically apprenticeship style learning. So you are attached to a particular hospital and the aim is for you to learn from your consultants. Okay, so you're pretty much learning the job day-to-day basis. Whereas an academy is a bit different. So because the UK particularly has a massive shortage of radiologists, the Department of Health, as well as the Royal College, have decided to create these academy hubs, which are away from hospitals. So it's very much like medical school. So these are separate buildings where you go and you spend a bit of time in a particular academy center where you'll get the teachers coming to you. So you'll get consultants coming to you, you'll get simulation. So it's very much more like medical school. So you'll be there maybe for like 3 months, 4 months, 5 months. And then afterwards, you'll then do your placements at the hospitals. The good thing about the academy, I personally think it's a bit more hand-holding, shall I say, and then you get a bit more in terms of the teaching, and then you get to implement all of the things that you've learned in academy over in the hospitals. So you can do a bit of research. Examples of academy style programs include Leeds, Wales has one, East of England has one as well. But we're getting quite a lot of hybrids at the moment between the traditional schemes as well as the academy schemes. So I've just given you, I'll share this PowerPoint afterwards, but essentially I've given you a list of all of the different types of programs that we've got. The biggest positive I would say as well with radiology is that once you secure a radiology number, you are pretty much protected in that particular geographical area, which is really, really helpful. I mean, it means that you're not having to move around. You can either, you know, rent a house, buy a house, live with your family, and you're pretty much secure for the entirety of your training program until you become a consultant. So the program that myself and Khalid are in, for instance, the furthest hospital away, it's like a 45-minute drive radius. So it's really, really tight program, which is quite helpful for us. So in terms of the structure of training, so radiology spans between 5-year training program as well as a 6-year training program based on whether or not you're doing diagnostic or interventional radiology. So I'm just going to quickly go through how it all works. So you finish medical school, you then do your 2 years of foundation program training, and then afterwards, either you can take an F3 year or you can apply directly, and inshallah, you'll then get accepted into the radiology training scheme. It is a 5-year training scheme, as I mentioned. However, if you want to do IR, it's an extra year on top. So you go up to ST6. Now, the thing is, a lot of people ask me, oh, how do I know whether or not I should do diagnostic or IR? You don't need to actually decide that. There are something called IR themed ST1 training numbers, which have been created purely because we've got such a shortage of interventional radiologists. So the actual competition isn't to get into IR. The competition is at the front door, which is to get into radiology. So don't be worried about, will I get into IR? Really, you just need to secure the ST1 number. Because the first 3 years, ST1, 2, and 3, we all do the exact same thing. And then when we get to ST4, that's when we start subspecializing. And that's when you either kind of go down the IR track or you go down the DR track. Even if you go down the DR track as well, you have to pick a subspecialty interest. And then once you finish that, you CCT and you start working as a consultant. So one other caveat that Khalid also touched upon is there is this other entry point, and this is specifically for IMG. So it's not for UK trainees, which is where they can apply to join us at the ST3 mark. So, and this is specifically for doctors who've got their press form signed, who are eligible to work in the UK. They have to have passed the first part of the FRCR called FRCR Part 1, and they have to have their competency signed off, which is what we would expect somebody for the ST1 and the ST2 year. But all of this information can be found on the RCO website. If you just type in ST3 recruitment, again, this is not for the UK doctors, this is specifically for our IMGs to join us at the ST3 level. So the FRCR, which is such a horrible exam. And I would say anesthetics is also quite a very, very difficult exam, I would say. So in terms of the FRCR, I'll explain to you quickly what the exam actually entails. So you sit, okay, one thing that I need to point out is unlike, MRCP or MRCS or MRCPCH, those type of exams, you get to pick when you want to essentially sit the exam. So it's essentially you pick when you sit the exam, whether you want to sit it in the spring sitting, winter sitting. What is very different about radiology is the RCR dictates when you sit the exam. So it's very much like medical school. You're expected to sit the exam. Everybody in the country will sit the exam at the same time as well. So the first part 1 is an anatomy and physics exam. And again, people freak out when they hear physics. I would say personally, I did not even do A-level physics. I did not do triple science at GCSE. I did double science. And I still managed to get through the anatomy and physics exam as well. FRCR Part 2A is a beast of exam, which is what I'm currently tackling. It's essentially a 6-hour exam where you cover the entire curriculum from neuroradiology to chest radiology to pediatric radiology to MSK radiology. So essentially, the exam is a knowledge-based exam. So there's no pictures, there's no radiological images for you to interpret. It's purely a knowledge exam. And the best thing, one of the most difficult exams you will ever do, because one thing about the radiology, we are the truest of truest generalists. Essentially, you need to know everything from every specialty. As a radiologist, you can't say like, oh, okay, I don't like pediatrics, or I don't like obs-gynae, or I don't like ophthalmology. You are expected to know the knowledge for every single one of the specialties that we cover. Another thing I would say that one of my consultants told me when I was a first year registrar is that as a radiologist, you need to be able to speak the language of the person asking you the question. And that has always stuck in my mind because during my on-call shift, for instance, I can have a consultant pediatrician coming in. The next person could be a gastroenterologist asking me a question. So you need to be able to switch up the knowledge and be able to, talk their language. And the final exam is the FLCR2B, which is an oral examination where you go to the Royal College, you'll have two consultants sitting either side, and you'll be expected to verbally report cases. So it's honestly one of the hardest, this is the hardest thing about radiology. It's the knowledge aspect, and it is strenuous to say the very least. So as I mentioned, subspecialty wise, so once you finish your core radiology, and when I say core radiology, that's your ST1, 2, and 3 years, then you move on to your subspecialty years. You can either go down the route, as I mentioned, interventional radiology, or you can pick one of the other diagnostic radiology specialities. One thing that I must note, I've given you guys a full list of all different types of subspecialties. However, people do mix and match. So, for example, somebody may become a musculoskeletal and chest radiologist. Somebody may become a GU and a gastro radiologist. So you can mix and match, or you can just pick one. So it's up to you how you want to kind of play it. So one thing that I always like to talk about is opportunities in training. One of the biggest benefits of kind of like leaving the local market, shall I say, and securing a national training number is that that training number is assigned to you. Okay, so you can go as fast as you want, or you can go as slow as you want, and you can do a mix and match approach, and you can create the training scheme for yourself as well. So, and this I don't think is really talked about that much. So I'll talk to you guys a bit more about that because I'm quite passionate about this as well. So I've given you guys a whole host of different things of people that I know and how they've kind of played the game. Essentially, you can take a year out to do a master's. So I know somebody who's kind of doing an artificial intelligence master's at university. Somebody has just come back into the program after doing a PhD. I know somebody else has done a year in industry. So one thing about radiology is there's this strong intersection between, especially people that are interested in medtech. So you can imagine there's a lot of like private companies who are constantly creating new technology. So whether it's new AI tools, new workflow tools that we use, or different ways of how to reduce radiation. So there's always industry at play, and especially when you go to any radiology conference, you will see who sponsors all of our conferences. There are people in tech. But there is this gap, right, of people that work in the tech industry, but you're the one that knows how to, for instance, kind of go in between that of how do we translate that into our everyday practice. So you can do that as well. You have the opportunity, for example, to apply for things called out of programs. So there's different types of out of programs. And by the way, these type of out of programs are not specific to radiology, it's for any specialty training that you want to do. So, but you have to give your training scheme notice. That's the big thing. You need to give them at least, I think they say usually 6-month notice. So you can go out of program for clinical experience. Let's say you want to do an attachment in Canada, for example, you can do that. If you want to take an out of program for research purposes, such as doing a PhD or a master's, you can do out of program for clinical training. So for instance, if you want to become a teaching fellow for a year, which is something that you can do in radiology, you can apply for that. Or another important thing, if you just want to take a career break, if you just want to take a career break, you can also do that as well. So this is where trainees can request a break for a designated agreed period of time to pursue other interests of theirs. And as I mentioned, get involved in industry. And earlier, as Khalid mentioned, if you've got a passion for teaching, you can do a PG cert as well in medical education. So just to talk to you about what is the day in the life of the radiology registrar. As Khalid also mentioned, it's really important that you do a taster week so you can actually see for yourself. So in terms of a normal working day, it's 9 to 5. And you get a mixture of lots of different things that we tend to do. So one thing that I emphasize is when radiology is truly a training scheme. It's a training program. So on your normal working day, everything that you're doing essentially is for you to develop as a radiologist. Okay. So we barely do service provision. which is very different from when I was a junior, where I was doing quite a lot of service provision type work. Whereas in our day-to-day, everything that you're doing is for your portfolio, for your development, for your learning. So things that we do is we do outpatient reporting. So chest CTs, for example, MRIs, X-rays, whatever it is that comes from an outpatient perspective. We also do inpatient work. So anything that's happening in A&E or on the wards, we can report those as well. Everything that we report as registrars gets checked. Okay, so we don't authorize anything in a normal working day. That is not, everything gets checked. We do vetting, which is when we have the lovely duty of answering the phone call to our colleagues and them asking us for scans. We do fluoroscopy, intervention lists, ultrasound, plain film sessions, teaching. So we all attend teaching every single week. So I'd go to teaching every Tuesday. So it's a whole day of teaching for myself. I think Khalid, because he's a first year, he gets more, like 2 days or 3 days a week. And audit work. So you do audit QI projects as well. Now, it sounds all lovely because that's what a normal working day is. But on call is a whole different story. That is when I always say that's when you're suffering. You're suffering for the daytime. So essentially, essentially what we do on call is, I'm sure all of you guys have spoken with the radiologists on call. And if you're a medical student, you will have the pleasure of speaking to us as well in the future. Essentially, our job is we vet scans, and we speak with every speciality you can imagine. Our bleeps are going off every few seconds. The phone call is going off non-stop. And our job is essentially to report all of the acute scans. One of the things that's different from the daytime is when you're on call, we authorize the scans ourselves because obviously of the urgent nature. And our consultants check it within 24 hours, which is really a lot of pressure, shall I say, because as you can imagine, you can have something really acute happening at 1 a.m. in the morning and you're authorizing it, and the patient can be taken to theatre based on what you've said. So it's a lot more pressure. It's a lot high, very, very high stakes. I still remember when I did my first ever on call as an ST2, I genuinely had angina because the first bleep that went off was a trauma alert and it was an RTC. I'll never forget it because I was just like, and you're by yourself and you're like, oh my God, I'm not ready for this. Another thing that we tend to do is also we deal with contrast reactions. So people have, I had one recently where a patient, start developing angioedema, urticaria. So, and you still have to be a medic and still have to deal with that kind of stuff as well. So I'm just going to give you guys a quick example of an on-call case. So this is genuinely something that I had on my on-call loss. And I'm just going to read out to you what, and I paraphrased it a little bit, but this is what my colleague from A&E said to me essentially. So, hello, radiology registrar. My name is Dr. A. I'm calling from A&E Majors. I have a 6-year-old patient who was playing basketball with his grandson, and he seemed to be enjoying playing as he was shooting a hoop, but he felt like he pulled a muscle. I thought it was a rotator cuff, but there's just something not sitting right with me. And there's pain in his abdomen, pain in his shoulder. He's got a past medical history of OA, the left shoulder, but he just does not look right to me. I want to scan him. I'm not so sure what scan. What do you think? So in terms of his odds, his blood pressure is running quite low at 8/50, which is odd. Oh, sorry about the noise. I think someone's getting sectioned around you. Anyway, about this guy, he really is not looking so good. So this is the kind of story that we will get from A&E. And I want you guys to have just a few think what kind of differentials you'd be thinking about. But just to kind of tell you how I would approach this particular thing, a particular scenario, you've got a lot of information that's been given to you in the span of less than a minute, right? So as a radiologist, our job is to constantly be thinking about differentials. So you really have to use all of the medical knowledge, all the surgical knowledge, all of the radiological knowledge in order to think to yourself, okay, what could this potentially be? What other questions do I need to ask? So often we've got quite a bad reputation of being quite mean on the phone, shall I say. But I'm always asking questions. I want to know what are the obs, what are the bloods, what did the gas show, what did the lactate show, what past medical history does the patient have, how does the patient actually look like? And I'm constantly quizzing my colleagues because I'm trying to either rule in or rule out certain differentials in my mind. And then afterwards, I need to also think about how can I protocol a scan to answer the clinical question that they are potentially worried about. And sometimes I also give suggestions about what I think, like, oh, okay, have you thought about this? Have you thought about that? Could this be it? Could this be that? So we have that two-way dialogue often with our colleagues. And often they may even come to us and say to me, look, we need a scan. We just don't know what is going on. He looks grey. And this is what the scan showed, essentially. So they were a bit thinking about the shoulder, thinking maybe an MI, but essentially this patient and what the CT scan is showing us is he had an abdominal aortic aneurysm rupture. Okay, so as a second-year radiology registrar, you're expected to essentially report this study independently, and rather than just like, reporting it by typing it out, you're expected, quickly do an urgent report, hot report on this, give your colleagues a call and let them know that, look, you're going to need vascular ASAP. The aneurysm has ruptured, this patient is hemorrhaging into the retroperitoneal space. And that is part of your role as a radiologist. I have also had to often go up to resus, so our reporting hot station in resus, particularly those are the major trauma cases, and it's always somebody's always getting stabbed, or it's a horse. For whatever reason, in the area that we are working in, people get hit by horses, kicked by horses. So often cases we'll get called up to resus and asked to just give the quickest verbal report so that they can take this patient to the theatre and do laparotomy. So moving on to what a typical job advert for a consultant radiologist is, because I don't know about everybody else, but my mentality was I have always been willing to work hard in training, right? I'm sure that is fine. But what I also think about is that the training scheme, whichever way you go, whether it's pediatrics, radiology, GP, training is the shortest part of your career, right? The longest part is life as a consultant. So you need to ask yourself, where do I fit in? What kind of consultant life am I seeking? So this is just a current job advert that's out. One of the things about radiology, as a full-time radiology consultant, you work 4 days a week. Part-time is even less. And those 4 days that you're working, you're not actually on site. Okay. So all consultants have, as they mentioned, virtually all of our consultants have home reporting workstations. And you work together with the hospital that's employing you to come up with a job plan. And the job plan can be negotiated. So it might mean, for example, you come to the hospital 2 days a week, you work home 1 day a week, and you get another day to do self-development where you just do things for your own education, or you get involved in medical student or radiology registrar teaching as well. So yeah. Now, just to talk quickly about the pros and cons of radiology. What I would say is, in terms of the pros, it's such an academic speciality. It is really, really an academic speciality. And I think one thing that I truly like about radiology is the fact that I can relate to all of my friends. So especially my friends from medical school who are doing different things, whether it's an ophthalmology friend of mine or a pediatric friend of mine, no matter what specialty, I can really relate to them. I can relate to the things that they're studying. I have such a broad level of knowledge, which is what I've always wanted. I never wanted to be pigeonholed in one particular area and forget all of my knowledge in other specialities. What else I would say about radiology is that is massive variety, massive variety. It's flexible. As I mentioned, you're a true generalist. You're very, very well valued because not a single MDT runs in the hospital without a radiologist present. And there's massive scope for research and innovation. I mean, they always talk about AI is going to come and take over. To be very honest, once you're in radiology, you'll understand how AI works with radiology rather than that they can replace you, essentially. The cons, I would say, FRCR is no joke. It is actually no joke. I have been absolutely suffering for this exam, but it will end, right? So that's the way I'm just kind of having to tell myself it's not something that's going to last forever. I get another con, some might see it as well, is that you are expected to essentially be a master of all, which is quite a lot. And another thing is, one thing about radiology is your mistakes are in black and white, right? So even if you reported a CT scan 5 years ago, so for example, sometimes I will see CT that I reported when I was a first year, and I'm like, oh, whoa, like who was that? And then you see it was yourself. So your things are out there in black and white. And another thing I would say is the workload is massive, mainly because A, the UK we don't have enough radiologists in the UK. B, we've got an aging population. C, I'm sure the doctors of you have noticed that what patient of yours gets through the hospital without some kind of scan? So you can imagine there's such a heavy reliance on medical imaging as well. Thought I would just play this.
You right? Dad? Good. Oh my God. I think he's having a heart attack. Call 911. Call 911. Dad, come down to the floor. Easy, easy, easy. Is there a doctor in here? All right, got you. Can you talk? Can you talk? Okay. Want some water? Huh? No? We got a doctor coming. Okay. Just squeeze as hard as you can. Okay. All right.
And the essence of that is we are still doctors. So that is the end of my presentation. Gonna stop sharing.
Thank you. So the link is in the chat to Slido. So if you want to post any questions in there, we have another 10 minutes and then for the Q&A. We've got a few questions already here ready, and they're open up to either of you.
Okay.
The first question is, I studied in Europe and got an MD for my degree. Does that count as part of the points? I'll give that to Dr. Kareem.
Unfortunately, I know a few IMGs who are applying for radiology as well, and they all ask the same question, but I don't think it does count. But again, if you do like put it in your portfolio, I don't think there's any harm in trying, because technically it is an MD, but I don't think technically it counts.
Okay, thank you. Next question is this. Does one taste a week over 3 days count as multiple exposures?
No.
No, it doesn't.
No. And can a taste a week be just 3 days?
So it has to be a minimum of 3 days, and it has to be 2 separate taster weeks that are different in sort of, they can't be in the same sort of setting or the same kind of situation. So for example, you can't do 2 taster weeks in the same department and say that's multiple exposures. That won't count. It has to be minimum of 3 days. Usually 5 days is what they offer people when they ask for taster weeks. But it is really easy to get 2 different sort of scenarios, whether that's IR or not, or whether that's a DGH or a tertiary center. Don't risk losing marks, because it's one of the domains where you can easily get full marks. So if I was you, I wouldn't risk it. Yes.
I think one thing that I would also add, when they say multiple exposure, I got full marks for that section because I literally did lots of different things and packaged it all together. So rather than just doing a tasty week, like for example, what they want to see, that whole domain is all about commitment to speciality, right? So they just want to see what evidence do you have that you're committed to radiology. If they give you a number, are you actually going to take it? So I did things such as go to a conference, letter from a conference, radiology teaching that I did for medical students, going to MDT and getting a letter from that, getting a letter from doing a taster week. So it's more about variety rather than just having a single taster week, essentially.
Okay, thank you. And next question is, what type of things would you do in medical school to improve your chances?
Oh, this is a great question. I can take this. So firstly, the reason why I like this question is because I did not realize as a medical student how much I could have done in order to prepare for specialty training. Because a lot of the things that you do as a medical student, will count for your postgraduate. It's not something that's really talked about, which is why the final session that we're doing is all about medical students and getting their portfolio sorted. So one thing that I would say is things that you can do. You can definitely do an audit. You can definitely do a quality improvement project as a medical student. Get involved with your local radiology department, getting a publication, getting a poster. There's so many essay competitions for medical students specifically. You can become a medical student representative at a national society. You can do medical student elective in radiology. That shows your commitment as well. You could do student selected components in radiology. What I would also say is to really get ahead of the game, especially if your medical school doesn't already have it, start a society, start a medical student society for radiology, and then put yourself as a president, right? So that also is a thing. But we'll talk a lot of detail about, because as a medical student, I wouldn't necessarily say pigeonhole yourself into one particular specialty. Create a portfolio that will give you multiple, will cover you for lots of different specialities, because every specialty, no matter what, wants things such as teaching, QI, audit, elective, SSMs, leadership positions, charity, altruistic things. So there's lots of ways to do it as a medical student to get ahead of the game.
Okay, that's good. Next question is, how many points would you need to be shortlisted for an interview, really?
So there's no, in terms of portfolio or MSRA or portfolio?
Portfolio.
There's no minimum number of points for portfolio. The sort of the way that they select people for interviews from the MSRA, and obviously that cutoff is getting higher. Last year was the year that just passed, it was 555. The portfolio was worth 20%, so it's not gonna. So even if you don't have an amazing portfolio, it doesn't sort of mean that you're not gonna have any chance of getting into radiology. It's only 20%. If you do get past the MSRA, and the main sort of hurdle is going to be the interview, and if you do well in the interview, then that sort of gives you a big chance to get a place. So even if you don't have like the most amazing portfolio, doesn't mean that you have no chance of getting in. It's only 20%. If you do well in the MSRA and you do well in the interview, which is 80% of the application, then you will easily, hopefully, get a place. But at the same time, don't neglect the portfolio. Try your best with the portfolio. You have at least 6 months from now, 5-6 months, so you can easily get a lot of points. An average score would be around 25 to 30 is what most people get, I reckon. Most people get around that point, around that. Only the proper dedicated people who've been thinking about radiology since they were in college or something get like above 35, 40. It's doable, but obviously you need a lot more time for that. But yeah, don't be too disheartened if your portfolio is not, the top 5-10%.
And one thing I would also just add is that a lot of people fall at the MSRA hurdle. For radiology specifically, it's MSRA that gets them. Because the thing with MSRA, you will only get an interview based purely on your MSRA, not your portfolio, nothing else, just your MSRA. So a lot of people get stuck at that point. They don't meet the cutoff MSRA. The next bit where people get stuck up is the interview, because you can imagine if you scored more than 555, for instance, everybody is in such a tight spot, right? All of the candidates are going to be ranging between 555 to like 610 or whatever. So they're really tight. So what will separate you guys all out will be an interview. The portfolio will help, but it will be an interview that will really tease out the candidates, I'd say. Yeah.
I think this was answered in the presentation, but it says, which year do you decide to subspecialize?
ST3. So
ST3.
thank you.
Yeah. Okay. And then when do you start reporting independently by yourself?
Okay. So as a first year, you don't do any on-calls. Okay. So you report, but everything will get checked. So you start reporting independently when you start your on-calls, which is from second year onwards. Now, one thing that I must add is that, and which is really important to know. There's a massive discrepancy across the UK about when a radiology registrar starts their on course. So Birmingham, in Khalid, we have it bad. We have it very bad because we started our on call. Well, I think Khalid, you're starting now in September, isn't it? Yeah. So we've got it bad because in Birmingham, the West Midlands region, you start your on calls from the second year, which is really a lot of pressure, in my opinion. For example, if you are one of my friends, she's a registrar in Kent, in Sussex, so KSS deanery, they do not do any night shifts for the entire training program. Another friend of two of my friends are in the Nottingham, so the East Midlands program, they don't start the on course until the third year. So it's all about very much where you are based as well. One of the benefits I would say about our West Midlands scheme is the fact that because you get thrown into the fire from second year onwards, you learn how to swim faster. I would definitely say you just learn because you're kind of stuck, so you have to. So yeah.
Okay, I think this should be our last question. Just question is, when is the deadline really for all this application process? And when do you submit your portfolio? Is it normally at the start of the application?
So the deadline, the Oreo opens in November. You submit the application where you fill in your details and like your sort of basic details, and then that gets submitted in December. That closes in December, sorry. And then you get invited for MSRA. You sit the MSRA, and then if you get past the MSRA and you get offered an interview, that's when you start submitting your evidence for your portfolio, and then that's when it gets checked to see if you've given yourself the right number of points. But yeah, your portfolio doesn't get checked unless you get to the interview stage.
Thank you.
We've got another question here. Can you become a radiation oncologist as a subspecialist, or is that only through IMT and then oncology?
Okay, so that is a route that you go through IMT. Okay, so there is similarity because we sit the same part one. So they also sit FRCR part one as well. But to become a radiation oncologist, you have to go through the medical route. The one thing that we do have that is similar between the IMT route and the radiology route is nuclear medicine. Or radiation and oncology is a whole separate pathway, and you have to do IMT.
IMT, okay. And I've got another question here. It says, I've never met a radiology reg at my DDH. Because they're all consultants. Is that normal?
Very, very good. Yeah, no, that's a very good question. Again, it really reflects how little there are of us. So across the country, I think the general rough intake per year across the whole of the UK is 350 radiology registrars every year. So that's tiny number in comparison to the whole country. So there are certain hospitals that do not have any radiology registrars. There are certain hospitals, not countries, certain hospitals do not have any radiology registrars whatsoever. It's completely a consultant-led place. There's certain hospitals, for instance, where after 5 o'clock, they have to send all of the scans over to Medica or Four Ways or whatever other teleradiology company there are, because again, they just don't have enough radiologists. So that's completely normal. In the bigger cities, definitely you'll see radiology registrars, but in the more like DJHs, for example, you can definitely have not a single radiology registrar in the hospital.
That's good. And another question here is, would an abstract at a conference with a taster week suffice?
That's two different domains. So
it is two different domains.
So the abstract at a conference wouldn't count for commitment to a specialty, but an abstract at a conference, whether it's a poster or an oral presentation, will get you points. So there are some occasions where you can use the same thing for multiple domains. So for example, if you do an audit, that will get you points in the audit section. And then if you present that audit at a conference, that will get you points in the domain after that. Can't remember what it's called, but you can get points for that. But I don't think you can get points for an abstract in the commitment, especially because it needs to be an experience, something that you've sort of seen when it comes to radiology or done. Yeah, I don't know if you want to add anything somewhere about.
No.
And have you ever heard of someone getting in with a portfolio score below 30?
Yeah. What was mine? I think my score was 33. But it's only 20%, as we mentioned before, it's only 20%. It's definitely not going to make or break your application. So if you can, you've got 6 months, try and improve your points. Try and get as much as you can and then focus on the MSRA, try and get through that hurdle. And then if you do get through that hurdle, inshallah, just focus on the interview. That will literally sort of get you in if you smash it. So I wouldn't worry too much.
Okay. And how much patient contact is there really during the training program, and which of the subspecialties have finished the most?
Okay, so great question. Because often people have the misconception that we don't see patients, which we definitely do. But so firstly, what I would say is you will have patient contact from first year, because anything such as ultrasound and fluoroscopy and anything that's intervention, you will have patient contact. Okay, so we see patients in some format every single week. Now, that's as a core training, as a year 1, year 2, year 3 registrar, you'll definitely be seeing patients. Now, from subspecialty onwards, it really does depend on what speciality that you do that will determine how much patient contact that you have. So, for instance, if you are a pediatric radiologist, you are seeing patients probably every single day. Especially because with pediatrics, they tend to prefer ultrasound. So you're seeing patients in that way, you're doing interventions. So you're seeing a lot of patient contact. Same for interventional radiology. Now, if you pick something such as neuroradiology, you'll have a lot less. You may have a fluoro study, a fluoro list per week. You may have absolutely nothing. You may have zero patient contact. So you can tailor it and pick something based on what your preference is as well. So that's how I would say. So it's very varied in radiology, and you can kind of pick your flavor essentially.
Okay. Just got a last minute question that just arrived. If you have an offer for radiology, can you defer your entry for the year after?
Yes, you can. I do know somebody that has done that. I know 2 people actually have done that, but you have to have a good reason. You can't just you have to have a good reason, and you need to speak with the training program director, explain your reason, and negotiate. But it's not a definite yes, that's for sure. But the 2 people that I know, they both had solid reasons for why they couldn't take their training number at that particular time, which so the deanery accepted. So it's very much something that you'll have to discuss once you've got the number.
Okay, thank you. I think that wraps it all up. I'm going to say thank you to our 2 beautiful and great speakers. I've left in the code to the feedback form in the chat, so if that could be done. And thank you so much for all joining today.
Amazing. Yes, if everybody could please fill it out, we'll just leave it in the chat and then we will wrap it up. But yeah, thank you so much. Next week we've got Ops and Gynae. So I hope you guys found it useful. And thank you so much, Khalid, as well, for taking the time. And thank you very much, Zakaria, for hosting.
All right, thank you.
Smash, should we stay here or?
No, that's it. I'm just gonna stay on just so that people have access to the Google Doc form. But you and Zaki can go.
All right, thank you very much, guys.
Thank you very much. Alexa.
Thank you, thank you.
Thank you. Okay, I'll just remain here for another couple of minutes whilst everybody takes down the Google Doc form. Thank you, guys. Appreciate it.